Hi, good afternoon. This is the final part, I think, or I hope, depending upon how long it goes on class on diabetes to Ayurveda to Ozampic. And this was supposed to be an Zoom class for OSHA USF, where I have done many classes, but due to some reason, it just didn't pan out. So I thought I'll record it and upload it on. So in this part, uh, originally, when the diabetic drugs were available, there was no reason or incentive to suggest that this will also work as diet drugs or weight loss drugs. But as more and more science became available, and in last few years, we have seen the explosion in popularity of Ozempic to treat the intricate part of type 2 diabetes, which is obesity. We talked about how the diabetic treatment changed from starvation to insulin, and insulin is an easy way to gain weight because it's a part of a growth hormone and makes you gain weight and is intricately connected in the food rationing or metabolism of all three big components. And as the science became more and more sophisticated and knowledgeable, but you can just see that the insulin received Nobel Prize in 1923, but there was a big sort of winter of lack of diabetic medications because even though we were able to keep people living, the mortality and morbidity which was associated with complications. And obviously, nobody enjoyed taking an injection or needle, the fear of needles that was there. So the research followed on the tails of sulfa drugs, which were the dramatic discovery, which was associated with the rise in organic chemistry and the first drug, the pill, the dyes that were investigated in Germany and opened the sulfadiazine, the antimicrobial drugs, and followed, which were soon replaced by antibiotics and antifungal drugs. But that's another story of antimicrobial therapy. But on the tails of this, there were attempts done again during the war and post-war Germany as early as 1942. Treatments were being developed as a derivative of sulfa drugs, which were marketed in Germany. But these were associated with toxicity, primarily liver toxicity, and some of the deaths occurred, especially in East Germany, which was less regulated. And so some of the drugs never actually made it to the so-called West. Okay, and then the first drug that was marketed by Upjohn Pharmaceuticals, called tobutamide, which was one of the sulfa analog drug that was marketed. But that was considered very revolutionary because it reduced the need for insulin, especially in type 2 diabetics. Now, this was questioned by an interesting congressman named, I think his name was Miller or something, and he questioned his daughter was diabetic, was taking this, and he questioned as to whether it was going to reduce the risk of heart disease and other things. But to their surprise and to their dismay, there were no trials that were done. So now at that time, NIH was flush with money, and a university group diabetic study called GUDP was carried out. At the same time, again, the scientific committee was learning how to do multi-center randomized trials. So, and that was, and there was relatively small studies done into various centers, and how the data was interpreted and was leaked to the public. That first, because the papers, there is always a delay in terms of after submission, and so the AMA and diabetic associations, there were some studies that were leaked to the press, and you can understand what can happen. And so then people did not like the outcome that was associated, that these drugs had higher morbidity and mortality. And that data was leaked to the public, and the scientists had a lot of explaining to do, and how the study was conducted, how the data was analyzed. And really, it was a lesson to be learned as to how to do a large study and deal with press that the physicians who were involved with learned. So there's a big story as to how lessons were learned, and people were finally there. Some of the results were analyzed as late as 30 or 40 years later in 90. And so in the so various headlines you can see were dramatic as to whether the public had hard time, accepting some of the results. And and this was again done with a fixed dose of insulin. So again, you can see how it was very difficult to come to terms. Okay, so that was a lesson that was learned by scientific community in a hard way. Okay, next. And then the management of diabetes, can be boiled down to two main objectives. First is to how effective the therapy is in terms of, now obviously in the early days, it was controlling the blood sugar and urine. That were the criteria. But then later on, hemoglobin A1C became the gold standard as to how effective the therapy was. At the same time, safety was of prima facie importance, because low blood sugar can lead to higher mortality. And as many more episodes of low blood sugar you have, you have a higher chance of dying from cardiovascular disease. And obviously, the biggest lesson that any physician has to learn during his or her career is to kill as few patients as possible. Okay, and the second generation of sulfonylurea had a long half-life, and especially if you had infection and you eat on an irregular basis, so then you're likely to die of low blood sugar. And so this was the FDA issued a warning on some of these drugs, as to how these drugs were marketed and were handed out like kidneys type of thing. So, and again, so all these factors need to be considered as to who we are treating, how long we are treating, what is their life expectancy, as to what our goals should be, what are their associated diseases such as kidney disease, and and what type of complications are we dealing with, and what type of whether patients can afford the drugs. So these are the very rigid control. This study was done in Britain in 1997 called UK-PDS, so diabetic group, and they attempted tight control and showed that yes, there were less complication by lowering the A1C, but at the same time there was a price to be paid, that if those who got hypoglycemia had higher mortality. And so as this was the balance that physicians had to deal with. And now, as recently, there are two main scientific bodies that have slightly different guidelines. The American Diabetic Association that deals with, while the highly specialized association, American Association of Clinical Endocrinologists, and their criteria is, obviously, endocrinologists are aiming for a lot tighter control of the hemoglobin A1C of 6.5. and the fasting blood sugar less than 110, to again prevent long-term complications. Okay, while the Diabetic Association is dealing with larger populations, so their criteria are a little bit more relaxed and probably more dealing with real life situation. Now, as diabetic is a multi-organ disease, as we learned over the last several talks, and it involves not just pancreas, but it involves the gut hormones, which help with the digestion and are intricately related, liver, which has a formation of glycogen and tries to maintain the homeostasis. Again, the type of fat that you have that we talked about in the ethnic studies, and the so-called brown fat, the good fat and the bad fat. And also, obviously, the kidneys have a lot to do with it, because obviously the kidneys absorb glucose. And again, when if the blood sugar is above 180, kidneys run out of their ability to reabsorb glucose and you start leaking. And that was the original way that diabetes was diagnosed as far as 2000 years back. So there are varieties of ways, it's like all roads lead to Rome, so to speak. So we have varieties of, and the first poster child that became, it's a available and was metformin, and there were some other drugs which were used in Europe and other parts of the world, but were slow to be used in. So for a long time, United States was stuck with using the sulfonylureas, which we talked about, which had higher problems, and insulin. And even though metformin was available in Europe for a long time, it was wait until the 1990s. Now, those of you who are clinicians will remember a drug called fenformin, which was marketed for a while, but it had complications with something called lactic acidosis, and that was, how the metabolism changed dramatically, and it was ended up with acidic blood and caused death. So that was withdrawn family. Okay, and I've seen some of the patients with that, and they had a fairly high risk of dying, and that was a challenge to treat. And it was kind of fun as a young physician, but again, so metformin. We'll talk more at length about metformin type of thing, and I think maybe my slides are a little bit out of sync type of thing. And let's see. I think if I can go back into the metformin slide, which was no, I think, yeah, okay, here we go. Yeah, this was metformin has a long history. It goes back to the early days of pharmacopoeia, or so-called nature medicine. It was related to folk medicine, the French lilac tree, something called go through. You can see the picture there. And that led to drugs which were called guanidine group of drugs that were marketed earlier. And but again, they had higher toxicity. So, and at the same time, they were useful for treatment of hypertension as well. So there were attempts which were done a long time ago in the early 30s. And some other drug that was marketed in Germany, I don't recall its name, but again, so a lot of these were tried for a short time and were withdrawn due to side effects. And now metformin has been around, as I mentioned, for a long time, and we're still learning it. One could say in broad terms that it works on the liver in terms of glycogen production, and it works now with the advent of molecular biology. We are learning that it works on the mitochondrial level, but it's still exactly where it works that people are still writing papers, and it reduces the so-called free fatty acid oxidation. Is a small but a definite effect on muscle utilization as well, and in terms of improving the insulin sensitivity of the muscles. Okay, now it works very quickly, it's effective, and the big advantage for the entire world is it's very cheap, and it may cost as less as $5, and it can be even received free through some of the big grocery chains. Okay, now the interesting thing that you may be surprised to hear that the Mount Sinai in New York is conducting a long-term study well-funded study for longevity. So metformin, in fact, some of the physicians and patients who are in the know are taking metformin for longevity, even though they don't have diabetes. And that will be a game changer if that study turns out to be positive. And it does have unlike the other sulfonylureas, which had adverse effect on heart disease and cardiovascular complication, metformin has a small but definite advantage for reducing cardiovascular complication, even as late as how far out as 10 years. The side effects is nausea, And so physicians have a learning curve. They have to start slowly and adjust the dose because that's one of the big cornerstone of therapy for diabetes. And it should be reduced if you have bad kidneys. Okay, and one of the effects of the other drug which we talked about was fenformin, it works with the various complex metabolic cycles. And it causes anaerobic metabolism, glycolysis, or breakdown of, without oxygen, and that cause the lactic acid built up and can be a very serious effect as very quickly and can lead to death. So the drug was rightly withdrawn. And okay, now let's go back to the big chart that I had earlier. So we talked about the metformin, which is really the first drug. Now it's still physicians have some quirkiness. At one of her physician said, "Oh, I just don't like metformin," and we were just taken aback. Really? Just because I don't like metformin? Now, I don't know what reasons we had, but needless to say, we changed the doctors. So the second group, which we talked about, was sulfonylureas, where the first stage. Now, as a physician, like I have an interesting story that there was a sulfonylurea, which was very popular back in the 70s and 80s, called diabetes. Okay. And this is an interesting story that kidney failure patients have a need for binding, agents called dialum that they take to prevent the toxicities from phosphates and calcium that takes place in the body. And that drug is called dialum, dialum, and diabetes, diabenes. So physician, the nephrologist had written prescription for dialum, okay, which is the binding agents for, for the bone changes that take place in chronic kidney failure patients. Okay, so but the pharmacist read that as diabetes. So even though this patient with kidney failure was due to hypertension, did not have diabetes, dispensed diabetes. And this poor African American lady was taking diabetes in fairly large doses, even though she did not have diabetes. Needless to say, she came with to our emergency room with a blood sugar of 27 and was in severe hypoglycemic crisis. So it just goes to show that sending prescription medications via electronic health records, where the physician's handwriting can be taken out of the loop, has some value to be seen. Now these drugs, the second generation of sulfonylureas, which are called glycine, okay, they work on pancreas by stimulating insulin, and which are glyburide and other drugs, which are very popular and cheap, but again, they don't have any dramatic benefit from cardiovascular point of view. So they are utilized far less now, and they're used in a developing world as a second-line drug after metformin, and can be used in combination and have a synergistic effect. Some of the other drugs, which I'm not going to address because there are like 12 different categories that are available. Okay, but we'll talk, but after in last 20 years, FDA and US has insisted that all of the diabetic drugs should be checked before they're released to the market for cardiovascular safety, so we don't end up with more heart attacks and deaths. So that increases the cost of marketing the drugs dramatically, at least in the US market. Okay, so we talked about that is the second group of drugs. And then for a while, there were groups which has a mouthful of a name called thiazolidine, but in short, they're called TZDs. So I'll talk a little bit about it as to how aftermarket studies have been involved in, preventing, in assessing the long-term effect when large number of population is exposed to. So they have a very complex way of acting. They work on increasing insulin sensitivity by a complex enzyme. Let me see if I can get to that, if I can find my slide. Yeah, here is one. That's the one. It's called the thioureanceladone. So mechanism of action is quite complicated. It works on, a very enzyme, which is, a receptor inside, the fatty tissue, and it increases it alters the transcription, means the actual action of the genes that are involved in glucose and lipid metabolism. So it works directly on the fat, at a very intracellular level, and is in glucose and lipid metabolism. So the drugs that were available, the names may be familiar with, especially at least amongst the physician group. The one that was available was called Actos and Avandia. I'm not going to go with the pharmaceutical names because they are a mouthful. Okay, and rosaglutisone and pioglitazone, those are the names. And one of them that was approved on a fast track approval was quickly withdrawn from the market due to deaths from liver failure. So you can see that as to how when the large number of people are exposed, and again, they have some bad effects which we do not want to deal with because they had increased risk of heart failure, and in contrast to the metformin and some of the newer kids on the block, they cause weight gain and cause leg edema, and they had some other side effects which were really unacceptable. Okay, let's see if I can get to that. Yes, yeah, here it is. They decreased, they worked like they were supposed to. They were cheap, once a day. And again, but the side effects like the weight gain and fluid retention were unacceptable, caused thinning of the bones, osteopenia, that's what it means. There is some question as to whether they cause bladder cancer or not. So they are used, far less, in the United States. There are better drugs that are available. Okay. And the interesting thing was that some cardiologists at the Cleveland Clinic had done studies on thioglutathione. Okay, and they did the meta-analysis of out of many studies that were available, and based on that, showed that one of this drug, Avandia, was responsible for higher incidence of heart disease and heart attacks rather, and deaths. So that maligned the drug. And again, obviously, once the respectable Cleveland Clinic does the study, the drug sales went down dramatically. And eventually, I think the company, if I recall correctly, the company decided to stop marketing the drug. But the other drug, which had which based on huge number of studies, had some benefit, is still available and being used, called Actos. But again, as I pointed out, due to a side that other drugs are available, so it's underutilized. Okay, and this is a huge amount of pharmaceutical armamentarium that is available to physicians in the United States. So to making choices, it's like being at a buffet restaurant. There are so many choices available, and it gets complicated. And it's hard to make your head spin almost to see how many drugs are available. Okay, and then again, we'll talk about the most important drugs which are not on this list, which are the GLP ones, which we're going to spend a considerable time talking about it. Now, the last group of drugs, which are newest one, they are called glucose transport inhibitors, which, because primarily, as I mentioned a little while ago, glucose is filtered and reabsorbed in the kidney. Okay, is filtered by the glomeruli, which are the cells on the outer layer of kidney, and they're reabsorbed in the tubules. So I'll have some slides for that later on. Okay, so and you can see when you pee glucose, it's beneficial because you're losing calories. So again, that will cause weight reduction. Okay, so these are the varieties of groups of drugs that are available. Okay, we I talked about metformin at length, and this is the whole list of diabetic drugs that are available. Let me see if I can open this link. This is from a respectable university. Okay. Yes, these are the number of drugs that are available. Metformin, thiolidines, I'm sorry, I'm just mispronouncing it. thiazolidines. Okay, so that's why you can see it is called TZD. The incretin therapy, which we'll talk about, these are the GLP-1 drugs that are popular. Okay, amylin is one of the smaller hormones, but we were not going to mention that. It's very okay. These are the drugs. The Orlinase tolbutamide that was marketed as early as 57. Okay, these are the second generation drugs. The glipizide, which is still on the market, gluburide, which was called diabeta, that some of you may be familiar with. Okay, and then and there are some other drugs which work in a different mechanisms, but we're very underutilized right now. Metformin is available in varieties of forms and drugs. Okay, and we talked about the TZDs. The Actos is the only one that's preferred. Avendia, that was rosiglitazone that the Cleveland Clinic study practically. Now the GLP-1 analogs that we'll talk about, interesting story, which was one of the main, the third part of the lecture, along with obesity and history of diabetes, that I was planning to. And there are varieties of drugs that are available, and the biggest one that we have available is the long-acting one that is available, and called Ozampic. These are the other drugs which are available, for excreting sugar through the unit, through the urine. The Genovia is the one which is most heavily advertised and used, and Jardiance is another drug that is heavily utilized now. And there are some combinations that are marketed now. But so this is, the whole market is, really very saturated and gets confusing, as we mentioned. So, okay, and this is another way of, this is where the brand names become familiar type of thing. And we talked about the metformin, which is the number one cornerstone. We talked about sulfonylurea is underutilized. These are, again, similarly work on potassium channels. The TZDs we talked about, and then the GLP-1 agonist, which we're going to be discussing in great details, but the cost is horrendous. It costs as much as $1,000 per month in the United States, and they're in short supply. Now, and the other way that is marketed is called DPP inhibitors. Now, the GLP-1, the glucagon-like peptide, is naturally occurring in the body, but it's very quickly destroyed by an enzyme called DPP. So people thought if we can prevent the breakdown of glucagon-like peptide, that would be useful. So that is the group of drug which is marketed here. They're moderately expensive. I put the dollar sign here. And these are the drugs that prevent the, make you pee sugar, okay, and make you reduce weight and control diabetes. And again, so that's just, another drug. I don't know why they kept these two names, Jardiance and Genovia, even though they're totally different. The names are very similar and can be very confusing to the patient and to some physicians as well. Okay, so these are the whole armamentaria that your doctor has available, and it really almost makes your head spin to try to memorize all of these. Now, at the same time, we should talk about some of the diet drugs. I have a list somewhere along the line of the common diet drugs that are available. The worst one that was marketed was one called Orlistat. That was, again, it actually make you poop fat. It bound, and there was Orlistat was one of the bitter pill, and another one was bound fat. It was called fake fat. So there was, got an award. The Dubious Award is the worst invention of 2010. And again, it was called, you actually leak fat in your poop. Okay. And obviously, so that did not catch on. Made you lose weight, but again, this was, it caused diarrhea and leakage, so that was not popular. And again, the algorithm that the Diabetic Association in their infinite wisdom puts out to physicians and is actually extremely complicated, and I don't think I'm going to dwell on this at the same time, unless you are going for MCAT or trying to pass your board exam. Okay, but the more simple thing is this way, that one of the UCSF physician had said, that this is a simplified version how physicians should make choice. Start with metformin, look for other comorbidities, whether you have heart failure, chronic kidney disease, whether you have high risk for heart disease or not, whether you're aiming for weight loss, or you have no other concerns if you're just an average Joe Smith who is obese. So if you have high blood pressure, you see this drug which make you lose sugar in your urine, and again you're using sodium also at the same time, okay, because you're putting out larger volume of urine. So that's why these are the drugs that are preferred. On the other hand, if you're high risk, then the GLP-1, which is the Ozampic-like drugs, are useful if you're aiming for weight loss. Then again, so these are the useful drugs, the Ozampic-like drugs. So no wonder the market is, people are gravitating for it, because as population gets older, a lot of us have risk for heart disease. So these are the drugs that are the, a darling of the not just medical community, but patients in general, and obviously the manufacturers, who are minting money in sitting in Denmark, and Eli Lilly, which is one of the big pharmaceutical giant for this company. Okay, and again, so you can just see that it was an interesting part of the history that from World War I onwards, drugs called nitrophenol was marketed, and again, varieties of drugs that were marketed for obesity. This is an old ad from 1940, and this is basically speed. You can just see amphetamine-based drug pills that were marketed by Clark Tabs, and so you can see that this was amphetamine 5 milligrams, and again, make you lose weight, but you get palpitations and you're putting stress on your heart. And so this was handed out, and I was working back in the late 70s or early 80s with a general practitioner, and who used to hand out this. People used to come from 70 miles away to get prescription for this. So we were trying to convince him that, yeah, this was a dumb thing to do, but it was hard to change his old man's habit. Again, it reduced the appetite, okay, and but again, it sped up your metabolism and it caused serious problems, okay, and again, it can, some other varieties of underground resurgence took place in the 1980s, and okay, and it caused a reduction in your cellular metabolism changes. It causes some dramatic changes at the intracellular level. In 1970, 8% of the prescription were for dexedrine, okay, but people developed tolerance, and again, that had problem with sleep, and some varieties of other treatment were tried, including wiring your jaw. Okay, so some drastic treatments were tried for weight reduction. So humanity has been struggling with obesity for a long time, and so varieties of treatments have been tried. And we'll talk a little bit more about the so-called fen-phen, which was popular in the 90s. Okay, let's jump right into it. Yes, this was that drug, which was a derivative of a stimulant drug called phentermine, and it was marketed with a serotonin inhibitor drug, okay, fenfluramine, okay, plus phentermine. So that's how the catchy name came up as fen-phen, fenfluramine, okay, which worked on the serotonin receptors, and phentermine, which was an stimulant type of drug, okay, and that became popular. As you can see, it even made the cover of Time magazine as a hot new diet pill, okay, and but unfortunately, and there were clinics that in Florida at any strip malls, people were setting out, and it became really a craze for weight reduction. And as it happens, the post-market studies caused some serious problem with pulmonary hypertension. There are two circulations. The one is the regular blood pressure, that is the arterial blood pressure, and the pulmonary hypertension. With this, there are the arteries that take blood to your lungs. They're called the pulmonary circulations. The two circulations are parallel and separate because the unoxygenated blood comes from your right side and goes to your lung, where it picks up oxygen. So two types of circulation. So pulmonary hypertension was a problem, and it also caused a scar tissue of the right side of the heart valves. in so much so that some people required heart valve replacement. And I think there was some PBS had done an article on this. Let's see if I can open this. Oh yeah, here it opens. Fan Nation. This was the whole frontline study that they did a very nice investigative reporting. Okay, you can see how. And so if you're interested, you can read as to how determined the population considered overweight and was marketed and used widely. And yes, another name that comes to is like very successful in moderate result. Okay, and then a pharmacologist combined the drugs in 1983, and a fen disaster. So there was a whole, rash of complications that took place. So it's a nice investigative journalistic story, as usual it does, the PBS does. Okay, but I think if you're interested, you can pursue that, but I think I'm not going to go too much into it right now. But that was a big, and I've seen cases of that, where people required tricuspid valve replacement. Okay, now we'll get down to, intestine creates certain hormones which are called, uh, controls your glucose, and these are called glucagon-like peptides. These are small molecules of protein which are called glucagon-like peptide 1, and glycogen like peptide, so GLP-1. So these are the two chemicals that are available, which we are going to talk about here. Let's see, I think, yep, here we are, and GLP and GIP, okay, agonists. So these are the main drugs that we wanted to talk about in this class. Okay, now, interestingly, this is called incretin-like. So these are the various peptides. So now they have a different effect, which is insulin is measured as C-peptide, which is another marker for endogenous insulin production. Now, normally one would expect that when you give glucose intravenously, the effect would be more dramatic. On the other hand, this was quite contradictory, that the C-peptide there was less effect after intravenous glucose than of oral glucose of this stimulation. Okay, so this was kind of a puzzling effect, and this was due to hormones that were secreted by a small intestine. So these are called incretins. So these are the other hormones which have a role in stimulating insulin. So it's not just pancreas that has the thing, but the other hormones that they are secreted by your small intestine walls. So this was got to be the incretin effect. So glucagon-like peptides, so this is how the groundbreaking discovery became available. Okay, and they increase your insulin level. So this is basically a glucose-dependent mechanism. Now, unfortunately, even though the body has so precise control that even these hormones are quickly released and stimulate insulin production, as evidence on this cartoon diagram. Okay, that but because of this, you don't want this particular peptide, which is part of a protein molecule, to be around for a long time. So it is very, very quickly destroyed by an enzyme called DPP, okay, diethyl polypeptide, so abbreviation that, so it's very quickly destroyed. So it is manufactured and is degraded quickly. And you can see this is the experimental work, as there is a lot of molecular work that's done, which we don't realize, that the laboratory science is valuable. And these were some of the biochemistry experiments that were done. This is a Denmark study. As you can see, this is how these molecules have been labeled. It's come down by the intestinal capillaries. It is immediately exposed to the DPP and is already degraded before it reaches, more than 50% of the secreted is degraded before it reaches plasma. So is released into the intestinal capillaries, exposed to DPP4. This is the enzyme. For those who are curious, it's called dipeptidyl peptidase. Okay, 4. So this is, and it's already degraded before it reaches circulation. Okay, and so a large amount of it comes quickly and it disappears equally quickly. Okay, so that's that was the problem. So somewhere along the line, the chemist had to work on it and make sure that it lasts longer to have an effect of stimulating insulin. Okay. Okay, now this is an interesting thing that I'm sure if you're watching late night TV, you've seen the commercial. Okay. Oh, I'm sorry, I can't play the tune. No, this was a. This was one of the songs that, this was a song from the 70s by a group called Pilot that the Ozampic commercial is based on. That's the magic. So I'm sorry that media does not play. I put that video in net, but still, so I think we'll just delete that so we don't run into that problem. And it's an interesting, it's just trivia. I think it's meaningless basically. So I'll delete this slide basically. Or hide the slide perhaps. Okay. I'm sorry, it didn't work. Okay. And again, the molecules, you can see the Science magazine gives out award as to the paradigm shift, as to it was a groundbreaking discovery. So you can just see every year they pick different scientific advances. Understandably, in 2020, it was the image of a black hole. 2019, there was a groundbreaking discovery by the Webb telescope, vaccines for COVID, protein structures, and the Webb telescope was results debuted in 2022. 2023, the breakthrough of the year, yes, Ozampic-like drugs, okay, which have really opened up floodgates, okay. Now, the molecule of the decade, now, initial drugs that were marketed were, required a twice-a-day injection, but once-a-week injection has changed dramatically the paradigm shift, basically. So the drug that is most popular is Ozampic, semaglutide. It was original indication was for type 2 diabetic, but when the study was broken, a lot of people lost as much as 15% of the weight, and now it is marketed, as a freestand, as a special drug, but under this larger dose for weight loss only. Okay, and it's so varieties of analogs have been developed, and it's a huge market that has taken place. And again, I showed you this slide earlier. So it's a reduced type 2 healthy subjects incretin effect. You can just see how the insulin is, but diabetics have lesser response to insulin, but they still have some effect with this. So you can see how oral is better than intravenous, so which is contrary to what so the substance is in released from your jejunal wall. It's a peptide, which is and it is by varieties of cells in the intestine are responsible for this. Okay, all right, moving right along. We already talked about this. Okay, now the GLP-1 is metabolized by this enzyme called dipeptidyl peptidase. You can see how this is gut lumen, and the varieties of toxins act on it, and from that the GLP-1 is released. Again, increase inflammation. GLP-1 is that it's isolated. It affects on the pancreas, heart. See all this. So these we already talked about the basic pathophysiology of it, and glucagon-like peptide. So that is effect not only just on pancreas but also on your heart and your brain. Okay, so this is okay. Some of the basic science that we have alluded to already at great length in the earlier series of lectures. Okay, and so with by it works on your gastric emptying. It affects on your satiety center. Okay, so it has a far-ranging effect. Interestingly, the research on that was done by a VA physician named Dr. John Eng, was working at the VA Bronx. They discovered the peptide in the venom of Gila monster, who eats almost like a once or twice a year basically, and it's able to control the appetite. Okay, so from that they isolated the molecule, which was chemically similar, and marketed as a drug called exendrin. Okay, and he found that this was very similar in structure to GLP-1, a hormone that is found in the pancreas that stimulates insulin reaction. Okay, and it fortunately it does not cause hypoglycemia because it works only when the glucose production is high. Okay, so generally primarily after eating, okay, and as we already talked about being destroyed. And so there are varieties of peptides that were discovered in the venom of this particular lizard. Okay, so and the native peptide has like a 30 amino acids. So they worked on the molecule, okay, to modify it so that the effect would be longer lasting. And the first drug that was marketed was twice a day injection called Byetta that was marketed as far back as 2005. But that required again more frequent injections, so it never caught on for the main weight reduction. And so it can be so varieties of the chemists got into the act and they modified the molecule by adding and playing around with certain amino acids and came up with this was the original drug exenaride. This is the native peptide, but they added some other amino acids, to modify the molecule. And it took varieties of work that was done was Ozampic. There was a biochemist, research scientist at MIT who named Daniel Drucker, who did a lot of the pioneer work along with other physicians from Denmark, at MIT, and Eastern European immigrant named Svetlana Motso was also, and later on afterwards, when she had family, she moved to Rockefeller University, and some of the people in Denmark were involved in work. So, at the University of Copenhagen, Jule Holst noticed that after intestinal surgery, glucagon increased people's insulin levels. So involvement of some intestine had some role in it. Now, Daniel Drucker, in the meantime, was working that there was glucagon-like peptides were had precursors called proglucagon. Okay, and he isolated varieties of chemicals distinct from a peptide called GLP-1. Okay, and okay, so it involved people not just from United States, but from Eastern Europe and Denmark to work on this particular. So there's a timeline for it was rather long, and let's see if I can show this. Okay, the Svetlana arrived in 1970. Okay, then she worked on GLP-1. Okay, at the same time. Okay, Daniel Drucker, who came from Toronto to MIT, and so he was working on inducing rat pancreas cells of glucagon-like substance. So and now there was some controversy that Svetlana was not given enough credit. Now I think I should hopefully try to set it up for slideshow for this, and then maybe this will play better. Okay, yeah, see, yes, now this will play better, I think. Yeah, so, and along with that, so they kept working on varieties of animal studies at that time, and finally, Novo Nordisk, the Danish giant company, marketed the first drug that was approved, and and later on, some of the other drugs that came around, and these people were rightly recognized with varieties of award. And the GLP-1 drugs now are estimated at 22 billion. Okay, so now this is the timeline. So let's see if I can. Okay, I think these are the individual slides. You can see how that it took almost 30 to 40 years for this to become practical from bench to the clinic. Okay. So it was a long journey. Okay, let's see again. If I can set that up as a slideshow. Yeah, it works this time. So I think basically, but it's it's a lot better when I go with the regular thing. So I'm just doing it on a so that we're working only with one molecule. Okay, so but unfortunately, as it happens quite often to women in science, that her work was uh, important but she was not recognized as varieties of awards that she for the work that was done. Okay, because again she moved from MIT to New York City, and she worked on in her paper. She was excluded in a variety of patents that were uh, issued for this, and even some of the prestigious award that was given. So there was a groundbreaking study that was done in Science magazine, which was like an expose. But that's the tragedy of sometimes science that works. So this is a prestigious Science magazine did this article on. This was about for Svetlana Mochso. So this is okay. So she was snubbed for this particular award. Okay. So it's an interesting article as to how the discrimination thing continues even in the modern era. Okay, let me get my slides back in. Uh, okay, and Daniel Drucker, and obviously, he recognized her work when he did not have anything to do with how. So he's a Canadian endocrinologist, and when he came to Harvard, he was assigned to work on glucagon, and he worked on the molecule that is that precedes the actual glucagon peptide, and he established the GLP-1 diabetic link, and he also had noticed the role with, he wanted to work on thyroid earlier, but as the hair professor says, he was assigned to work on diabetes, and the rest is history. It demonstrated that it also works on the brain. And there are receptors for GLP-1 all over your body. So this was the groundbreaking effect on the epithelium of first the small animals, and then again they also subsequently identified the dipeptidyl molecule that we talked about a little while ago. Okay, so now the GLP-1 has wide-ranging effect, as we talked about, not just on pancreas by increasing insulin secretion, beta cell proliferation. It prevents the gut emptying, so that's why you feel full and don't overeat. It works on your brain. It reduces your appetite. You feel full and some type of a neuroprotection. And again, there may be some role in preventing addiction as well. Okay, it has a beneficial effect on glucose. Okay, it reduces the fatty livers type of thing. It reduces inflammation. So, I mean, after seeing all this effect, one would be almost tempted to put it in your water that comes. So, okay, but it's you can see that these are really the groundbreaking discovery that was done by from lab to. Okay, and it works on the varieties of nucleus in your brain, which is a so-called reward center for food that has it effects called nucleus accumbens. Okay, so if you get food, you get pleasure and satiety center. So it works on the part of your brain called hypothalamus, which has a lot to do with our, feeling of response to food. Okay, all right. So, and these are the again for cardiovascular studies that have been prone. It reduces the hardening of arteries. So these were the two cardiovascular risk has been reduced in because as mentioned earlier, that is required uh, for treatment of diabetes. So the efficacy. So when this really become a groundbreaking, so in varieties of special mouse, it showed that it reduced the plaque development, and was a separate effect that it took place. So in it, varieties of markers for inflammation that take place in the body were also improved. As you can see that the Western diet was fed, they were treated with this type of drugs and their plaque went down. So, and again, the triglyceride metabolism improved. Okay, so overall, this was a very encouraging data that was available. Okay, and we talked about on the brain, it reduces, it may have some potential benefit, in terms of reducing the plaques, and by reducing the hypertension and inflammatory process, there will be some reduction on, the microglia and endorphins pathway. So there is, overall the benefit is quite encouraging. Now, this again has not been completely established. And as we talked about that some people noticed that they were drinking less. So alcohol use disorder and substance abuse, they may have a small but definite role, okay, in terms of what you choose as to how the other drugs, other addictions can be affected. So these are the varieties of peptides that work on your brain. These are the complex centers that we talked about, the nucleus accumbens, okay, which it stands for NAC right around here, as you can see, and ventral tegmental area. Okay, so these are the varieties of areas in the brain which have to do with our behavior, okay, and they're specifically localized, and you can see that the GLP-1s have a dramatic effect on these regions. Okay, GIP, it's a gastric inhibitory peptide. That's another hormone that is equally implicated. It's an incretin hormone that works on the special types of cells that stimulate your insulin and maintain your homeostasis. Okay, and so these were, again, so it's a quite complicated type of thing. So these are related to your obesity, and the circus that goes from intestine to pancreas is effectively involved. And again, type 2 diabetes, these hormones are adversely affected. So incretins contribute to about a large portion to insulin release. Okay, so that is responsible for glucose intolerance that takes place. So it makes sense that that has a lot of role in treatment of diabetes. Okay. And again, some of these studies that were done were groundbreaking studies. You can see people lost as much as 14% of weight, which is the most dramatic effect that has been seen with any currently available drugs. Okay, and this was again a groundbreaking report that was done. So, and almost the floodgates opened up. That's a game changer for the company. Okay, and this was like similar to, and can say, the enthusiasm that was there for Viagra, that was originally marketed for pulmonary hypertension and for chest pains, and people reported that yes, they are also getting erection. So that was the game changer event. So this was a big and a groundbreaker, and for the first time we have a treatment available to treat the complex. Now, how would it be for long term, that is hard to say, because if we are messing with your receptors and hormones in the brain, so hopefully we will not get the same problem that we had with fen-phen, when huge number of people are exposed. Okay, and again, this is an interesting experience that fen-phen, I'm not going to show this, but for the fasting or that the Muslim undertake, the Ozampic, that made it fasting very easier. So there was a satire on it, but I'm not going to show this to you for the sake of time. So these are the new kids on the block, the diet drugs, which are the GLP-1. Now, orlistat we talked about, but they are fallen by the wayside. And interesting that I'll have a couple of more slides. Is marketed as a combination of naltrexone. So this is obviously the drug that is given for overdose. People are overdosing on heroin and fentanyl. Naloxone is given. The paramedics will give an injection that is combined with a drug that was marketed for a while under a different name. Was an antidepressant drug to help people quit smoking. Okay, so this was, and so one drug company has marketed this for food addiction, and it has had some benefit in weight reduction. Okay, and I'll have some slides about that afterward. Okay, and this we already talked about, that for cardiovascular problems, There's been a benefit with Ozampic, semaglutide is a form, and this is a study from the prestigious New England Journal that came out, I think it was 2023 or so, semaglutide cardiovascular effect in obesity without diabetes. Okay, so indication has been expanded, and again, for even if you have a normal heart failure due to hypertension and heart is not necessarily weak, it has been beneficial. Okay, and so again, these are some of the more data that the heart failure data really looks promising. Now, mean coronary event, this is what mean combined coronary event type of thing. So the data is useful. Heart failure was beneficial, composite kidney outcome. So heart failure risk has been dramatically improved with this particular group of drugs. Again, so there is a big comparative study, but I think now that's getting into too many details. Now, some of the side effects may be poorly tolerated by some people that may cause nausea, constipation. Some have been rare cases of pancreatitis where pancreatitis is a very severe disease, and unless diagnosed and treated quickly, people can die from it. So, and again, the weight loss can be, and sometimes people get loss of the muscle mass and can become weak, and the people's face gets like a hollowed out appearance. So the signs of aging and wrinkles. So again, that leads to more plastic surgery, I suspect, as time goes by. So this is, the evidence-based medicine, is being used for systematic research. So how all of this will pan out, with time, as time goes along, that remains to be seen. So it's a huge market, and it's, you can just see how it's highest in Europe type of thing, and again, it has had impact in other fields as well. People are drinking less. Fast food market has gone down, and even the so-called diet books are less popular. So there's, so the effect of this drug is wide-ranging in many fields. Okay, so I was surprised to see that the diet books, which were the staple of self-help books at your local bookstore, are falling less. Okay, and so then in some variety. So now again, there is a new drug that is being marketed by one of the pharmaceuticals that has most of the loss was so less muscle loss that is taking place. So people are trying to find ways around it. Now, if inhibiting the GLP-1 and GIP are useful, so there is a kind of a triple drug that is being researched by Eli Lilly that not only blocks the GIP and GLP, okay, and it also blocks glucagon. So it's a triple whammy, so to speak. Again, that will be very potent, or will it have side effects or not, remains to be seen. Okay. Now, we talked about the last group of drug that we need to address is the SGLT2 inhibitors. As I emphasized earlier, that they work on kidneys, the target organ. Kidneys absorb glucose as it goes. It's filtered from the glomeruli, which are the network at the beginning of each nephron, and it is reabsorbed in the tubules and collecting drug because you don't want to use glucose. Now, if you have diabetes, if you have a high number and kidneys say enough is enough, and then you peak glucose. That was the original way of glycosuria, and that's how diabetic was diagnosed. But that's by inhibiting, the absorption of glucose, that you pee glucose. Again, peeing sugar in your urine has a risk for causing infection, but at the same time, they do work for reducing hemoglobin A1C and some weight loss because you're losing calories. Okay, and so these are the drugs which you may recognize. The commercial for the most popular one is Jardiance. Okay, that you see. Again, these are not cheap, cheaper than the other drugs that are available, and that they work. They do not need insulin because you're peeing sugar, so they have a far less risk of low blood sugar. And again, there is a beneficial effect that if you're losing sodium, you're going to be weight reduction, and other stuff is going to be beneficial. But the price that you pay is you can get fungal infection, more chance of urinary tract infection. At the same time, if you don't eat properly, you can get dehydrated. So there are some side effects that, okay. Now, so this is, again, to repeat, this is the therapy, monotherapy with metformin, okay, then combined with other, because we have other things, you're adding other agents such as the more expensive drug that we talked about, Ozampic, or the drugs that help you get rid of your sugar, okay. Now, this is obviously in the rich countries that is available, okay. It's a totally different ball game for developing countries. Now, this again goes down to the basic biochemistry for refresher and the science befinias. So as glucose is picked up by, various receptors, it goes through the cycle called Krebs cycle. It turns into energy. And here again, the sulfonylureas, this is how it works on so-called potassium and calcium channels. Okay. And then varieties of other drugs that are involved. You can just see these are the peptides that we talked about, which have a role in breaking now your ATP and into various works on various intracellular mechanism releasing insulin. This is how the GIP peptides work. Okay, and so this is the complex how we are basically learning the intracellular communication, cell-to-cell metabolism that is related. Okay. Now the weight loss drugs then that we talked about how effective that these are the phentermine, which cause very minimal loss and never caught on. Contrave, this is the new kid on the block, which talks with your food addiction. Okay, Orlistat has fallen by the wayside. Okay, and there's again, so this one, oily discharge from the bottom, so that never caught on. And this is the food addiction slide that we talked about, naltrexone, an opioid antagonist, and buprenorphine, and it's a inhibitor of the dopamine receptor, and it was used for helping quit cigarette smoking. Okay, and it's been combined. So this works on. Okay, and again, there are contraindications because you're working with with your brain receptors, so that can have some side effects. Okay. Last but not the least, if people have kidney failure and if they're lucky enough to find a donor and for multiple organs, then kidney and pancreas transplant at the same time can have a dramatic effect. This was done, from Canada earlier, and combined the islet cell that are transplanted into recipient. Okay, so this was the so-called Edmonton protocol. And so it can be a freestanding pancreas transplant, kidney and pancreas. Okay, so there are varieties of organs that are done, but that is limited by the availability of organs. Okay, so but it does have a small but definitely dramatic effect. Okay, now interestingly, some women have had problem with infertility due to polycystic ovary syndrome, because of these ovaries they produce more androgens, so that's why they're not able to conceive. So after losing weight with Ozempic, that's been a surprise that they have become pregnant. So there's been some fringe benefit that not the weight loss change, but a disease of gynecological abnormality called polycystic ovarian disease, and they've had improved, chance of having babies. Okay, and again, this was a drug that is used rarely for a monoclonal antibody that is used for type 1 diabetic, but that's not part of our talk. Varieties of bariatric surgeries were immensely popular, and they're still around, they still work, but the number I'm sure will go down due to availability of Ozempic. And this was a big business for surgeons that there were done some gastric banding that was done to reduce the amount, and again bypassing your stomach to causing a Roux-en-Y, okay, duodenal switch, vertical sleeve gastrectomy. As you can see how they reduced, so again, you'd be able to eat less, you feel full, and it's been successful. Some patients who are addicted managed to work around this by drinking milkshake with straw. Okay, and so so it doesn't always work, but the results have been dramatically beneficial. When it works, it really works. All the good parameters take place by reducing heart disease, reversing diabetes, reducing arthritis. So overall, when the surgery is, but obviously, as it goes on with surgery, it has its risk of infection and other complications. This was a slide for how all these 3 drugs work. It's a nice summary of all. Let's see if I can play this.
drug class, GLP-1 diabetes drug classes are marketed as treatments for people with type 2 diabetes. Blood glucose does not control the metformin.
Each drug class has a different mechanism by which it decreases blood glucose. The first drug class, SGLT2 inhibitors, blocks sodium glucose co-transport, leading to glucose reabsorption.
The second drug class, GLP-1 agonists, increase insulin secretion and decrease glucagon.
The third, DPP4 inhibitors, increases increased levels of GLP-1 and GIP, which increases insulin and decreases glucagon.
All three classes lower glucose, and some trials show that the drugs reduce all-cause and cardiovascular mortality. Researchers have now compared the efficacy and safety of the three classes using network meta-analysis, which lets them make comparisons across trials that weren't made in the individual trials themselves. SGLT2 inhibitors and GLP-1 agonists, but not DPP4 inhibitors, reduce all-cause and cardiovascular mortality, with no difference between the two.
Each drug class had associated risks. SGLT2 inhibitors were associated with increased risk of genital cell infections, mostly mycosis. GLP-1 agonists were associated with adverse events leading to trial withdrawal. DPP4 inhibitors were associated with increased risk of pancreatitis and retinopathy.
Based on these findings, SGLT2 inhibitors and GLP-1 agonists may be preferred over DPP4 inhibitors as add-on therapies to metformin.
Okay, so that was a nice revision that, and I'm sure that, so this was JAMA network, so hopefully it is placed. Okay, I think now I'm not going to go over this. Now, again, the biggest problem that we have, especially in the United States, is the cost. Metformin is dirt cheap, but when you get down to the so-called DPP one, the cost starts going up. Thiazolidone, again, not popular because of the effect of fluid retention and increased cardiovascular risk in some patients, although that was controversial. And one of the drugs is still around, is sulfonylureas. They're kind of second line, but again, in the United States, we go for the best all the time. So they're fallen by the wayside, but hey, they're around and widely used all over the world. And this is, the GLP-1 drugs. This is not a complete set because it does not include Ozampic, which is a game changer, and the cost is almost like $1,000 per month. Again, this is the Jardiance, which we talked about, where we are peeing sugar. Cost is $400. Now, this may surprise you that Ozampic cost in Canada is $155, $122 in Denmark, $71 in France, $50, and that's, but then the cost of Wegovy is $1,400, almost $1,349 in United States, $265 in Canada, and so on and so forth. $82 in UK. Okay. At the same time, some of these drugs that we talked about, in India, they are marketed by companies, they can be cost as little as $1 or $2. So it's an American tragedy. And the pharmaceutical executives, which cost the drug only costs $5 to make, and so Bernie Sanders had invited Novo Nordisk directors and CEOs, and they made some remark that yes, they may be willing to consider it, but they kind of initially were reluctant, obviously, to do that because they're laughing all the way to the bank. So that's the end of the. So we can just see we have gone from of a big problem from diabetes to obesity to we're trying to find a drug solution. And hopefully it was fun for most of you who have listened to this. Okay, I'll stop it here, and unfortunately, and I'll put it on YouTube for anybody who is willing to spend time and is interested in this very important subject. Okay, goodbye, folks.